Good afternoon again, committee.
Good afternoon, Madam Chair.
Today is Wednesday, January 28th. Our afternoon briefings begin with a briefing on SNAP and the work group on children in unlicensed settings and pediatric hospital overstay. The SNAP update will be presented by the Maryland Department of Human Services, Webster Yee, Chief of Staff, and Larry Handerham, Assistant Secretary for the program. Thank you, gentlemen.
Good afternoon, Madam Chair, Mr. Vice Chair, members of the committee. My name is Webster Yee. I serve as the Chief of Staff for the Maryland Department of Human Services. To my left is my colleague, Larry Handerhan, our Assistant Secretary for Programs. Mr. Handerhan comes to us from both the U.S. Department of Health and Human Services Administration for Children and Families and also the D.C. Department of Human Services. Just joined at the end of last fall. We gave him two very important homework assignments right off the get-go. The first is HR 1, what we call the One Big Beautiful Bill implementation. So he leads implementation across the department, in addition to audit compliance issues, both of which are topics that this committee is interested in today. So with that, we'll keep on going. There are hard copy slides and materials in front of you. I'll reference them, and again, happy to take questions at any point. First, SNAP, the Supplemental Nutrition Assistance Program, is vital to America's social safety net. I think we all saw an example of that last fall, in October, November, when the federal government entered the longest shutdown in history. SNAP is vital because in Maryland, it serves over 680,000 Marylanders. And in slide 2, you'll see the breakdown. It's really important to note, of the 680,000 Marylanders, 260,000 of them are children. I want to put this in context. We have $1.6 billion that we issue annually. There are federal benefits prior to this year that we issue to Marylanders. The average monthly benefit per person is only $180. It's not a large sum of money. And again, a third of our customers are kids. Let's see, the next slide here, and again, your hard copy slides are going to be easier to read. We've broken down the customers served by county and by region. And especially, this is every jurisdiction is impacted. Anytime there's a change to SNAP, anytime there's a change or pause in federal funding, the impact affects a lot of people and specifically affects a lot of kids. When the Trump administration stopped funding SNAP with the federal government shutdown, we were able to continue funding October 2025 SNAP benefits using carried over federal funds. Those funds ran out for our November benefits, and so starting on November 1st, we were not able to issue federal SNAP benefits. Governor Moore, as many of you know, declared a state of emergency. And the administration took two very concrete steps. The first was it announced and we issued over $10 million, or a $10 million emergency grant to support Maryland's food banks and over 100 community food partners. And we got that money out in about 2 or 3 weeks and made sure that we were out to help support Marylanders as quickly as possible. The second action that the governor took was to make $62 million in state funds available to make SNAP customers whole, following a federal judge's order that the federal government provide contingency funding. There was an immense amount of conflicting, if not completely contradictory guidance from the federal government during this period. All of our technical colleagues and program implementation colleagues made this work as quickly as possible, and they worked nights and days, weekends, et cetera, to ensure that by November 18th, once the federal government shutdown ended, we got full SNAP benefits out the door. And so I'll turn it over to Mr. Handerhan for more discussion on how HR 1 impacts Marylanders.
Good afternoon, everyone. Again, Larry Handerhan. I'm an Assistant Secretary for Programs at DHS. I'm going to talk a little bit about the impact of HR 1. I'll start off with the eligibility obstacles and restrictions, including reduced benefit values that are currently in place, and then pivot to some of the costs that the state can expect down the line. So as my colleague Webster mentioned, we had a lot of changes in the SNAP program due to the federal shutdown in November. I think it obscured the fact that November 1st was also the implementation deadline for many of the HR 1 changes that impact Marylanders. So I'm going to talk about each of these in a little bit more detail, but they include new work requirements that are in effect, the elimination of eligibility for refugees and people granted asylum unless they are also LPRs, lawful permanent residents, as well as some changes to the standard utility allowance. What I think is important, just to level set where we are today, any new applicants are immediately subject to these changes if they are presenting in our service centers or seeking benefits through the One App and other vehicles. For current participants of the program, they'll feel the effect of these changes over the coming months as they present for their redetermination for SNAP, which generally happens every 6 months. So first off, expanded work requirements. So historically, the ABOD acronym stands for able-bodied adults without dependents, and they have been subject to work requirements in SNAP historically. We know how to do this as a department. What is different is that an additional 80,000 Marylanders will be subject to these work requirements. That includes adults age 55 to 64, adults 18 to 64 who have a child younger, who do not have a child younger than 14. I think about this as parents of teenagers because this used to be 18, as well as groups that were categorically exempted like veterans, individuals experiencing homelessness, and former foster youth. So what does this mean? That means that these individuals, up to 80,000 people, must be working, volunteering, or in an employment and training program for approximately 20 hours a week. And education doesn't really count. This is different from some of the changes in Medicaid, which are going to hit the state later per the timeline for the implementation of HR 1. Because how the law is written and Maryland's minimum wage, that translates to about 14.5 hours of paid work a week to meet the requirement. So I think that is just one example of the complexity of implementing this and communicating this to our customers. If an individual does not meet the work requirements, they can only receive SNAP for 3 months in any 36-month period. That hasn't changed. It just applies to many more people. We put together this chart because of the complexity of the changes. So it just tells you a little bit about what was happening to this group of recipients before HR 1 and after. I think the thing that I would note here is that people who are disabled, who are in an alcohol or drug treatment program, or who are, quote, mentally or physically unfit for employment are exempted. That does not change with this law. The second area I want to talk about, we kind of think about as a reduced benefit value. So this is not about eliminating eligibility, but it is going to mean that Marylanders see a smaller SNAP benefit. So we have something in the state called Heat and Eat, and it's related to the standard utility allowance. This is a deduction that allows people who receive utility assistance to get a higher SNAP benefit amount. Through HR 1, you are only automatically eligible for this deduction if you have an elderly or disabled member of your household. You might still be able to prove your eligibility by sharing your utility bills, but that's an administrative burden that people have historically not had to present and jump through that they will have to moving forward. So it's another group that we'll have to make sure, and we are making sure that our messaging is tailored to. And finally, as I previewed earlier, HR 1 removes eligibility for SNAP from refugees and people granted asylum. That changes once they get their green card, which is turning to a status of lawful permanent residence. And there's some other exceptions listed on the slide here, including Cuban and Haitian entrants or individuals from Micronesia and the Marshall Islands. But in general, refugees and asylees, as of today and moving forward, are not eligible for SNAP. There's been a lot of unclear guidance that we've been working to get clarification on. We are currently processing the law as intended, but this has been an area where it has been a little difficult to understand the intent of HR 1. So we're doing everything we can to make sure we're clarifying that with our federal partners. All right, I'm going to pivot a little bit away from the customer-specific impact and talk about the impacts to the state of Maryland. Historically, SNAP has shared the administrative cost 50-50 between the states and the federal government. But beginning October 1st of this year, that will change to 75-25%, meaning that the cost to administer the program will be borne 75% by the state. So we have historically been spending $115 million of general fund dollars to administer this program. That is going to increase in state fiscal year 27, prorated, given when it comes into effect. And then moving forward, we'll be spending about $158 million to administer the program. I would just say that this is a tough fiscal reality that all states are dealing with, and is just one of the impacts of the shifting cost burden from the federal government to states and HR 1.
In addition to making life a lot more difficult for Marylanders, it also makes life a lot more difficult for Maryland taxpayers. One of the areas that we're going to talk about is the SNAP payment error rate. And HR 1 contained a provision where if a state, in Maryland's case, is over a SNAP payment error rate, or PER, of over 10%, it will be responsible for 15% of the previously 100% federally funded benefit costs. As of October 1st, 2027, we estimate that amount will be about $240 million. It's really important to note that the final cost share amount will be based on our federal fiscal year 25 or federal fiscal year 26 payment error rate. The SNAP payment error rate is a federally calculated statistic that measures a federal fiscal year. So it closes for federal fiscal year 25 last September 30th, but is only released in June of the year after. So we'll get our federal fiscal year 25 rate from the federal government on or about June 30th of this year. And that's a huge lag, because anything that we change or do is about a 9-month lag in what we can do. So all of the things that we've done over the past 18 months will show up about a year from now, just like the work that we've done 18 months ago is finally showing up here. And again, there's a specific 6-page handout that goes into this in a lot more detail. Happy to take questions on this. I just wanted to emphasize a couple key items. The SNAP payment error rate is not a measure of customer fraud, nor is it a measure of state fraud, waste, or abuse. Specifically, the SNAP payment error rate is a federal measure of how states administer the SNAP benefit and determine eligibility and benefit amounts by checking the number of under or overpayments. We're going to go into that in a little bit more detail, but it's important to note that this is a quality control check on our administrative processes. As you can see on this very fun graphic, Maryland had the second largest reduction in SNAP error rate in the country from federal fiscal year 22 to 24. Perhaps most importantly, the only state that was higher was Alaska, which asked for, and they got an exception in HR 1. As you can see, measured against our peer and surrounding states, we're roughly right in the middle. To be really clear, this administration is committed to reducing the error rate as much as possible. We have taken steps since 2023 to drive that number down. We've reduced it by more than 60%. For federal fiscal year 23, it was at 35%. We dropped it down to 13.64%, and we anticipate that in the next release of federal statistics in June, that our number will come down more. The 3 key factors in reducing SNAP payment and errors the first is staffing. We had high vacancies. We've reduced the vacancy numbers. We've trained our staff. We've been very consistent in training our staff so that you get the same level of service in Montgomery County, Anne Arundel County, or any of the western or eastern extremities. It's also important to note that a lot of our errors occurred due to IT system issues as we transitioned from a previous system to a new technology system early in 2020, 21, and 22, and we've now fixed a lot of those technology issues. And then the third one is, as my colleague Larry indicated earlier, changes in federal policy. In 2020, 21, and 22, there were immense changes due to the various COVID emergencies. And then more recently, we fully expect that with all of the litigation and dispute and discussion about SNAP error policy changes for HR 1, that will also impact SNAP payment error rate. This is a lot of numbers. I don't do math, I'm sorry, folks. But I will point out that this is the statistical sampling used to calculate our SNAP payment error rate. It's important to note that from these samples, you get that 13% error rate. And as you can see, the sampled cases, about 1,100 cases, and the dollar amounts are relatively low. On slide 2, I started the slide with, we are giving benefits to 680,000 customers. We issue a monthly benefit of about $180. And as you can see, the average error amount for overpayments is $246, or the average error amount is $205 in underpayment. So this is a relatively small amount, but it's extrapolated to a deeply punitive against the state's measure in H.R. 1. And so what are we doing about it? We are taking steps to reduce and fight the SNAP payment error rate to the maximum extent possible. Back in April 2022, our staff vacancy rate was 19%. We've reduced that as of about a week ago to about 4.28%. So basically, as soon as a position comes vacant, we start hiring for it. And in fact, we are doing continuous hiring to ensure that every single caseworker we get, we start a training process, we give them the standardized training, and then we get them in. And it takes a good amount of time to train a caseworker so that they're evaluating an application correctly. Second, as I mentioned earlier, we're using technology. We're trying to be smart about it. We're using AI-powered trainings. We're automating functions for example, no change periodic reports, so that our staff work smarter, not harder. And then third, we are looking across the country to see what can we do better. And so one of the big new items that's out there for the states is the National Accuracy Clearinghouse. It's a new initiative that the United States Department of Agriculture is launching. We're partners in it. We're also working with folks like Georgetown University, Code for America, Maryland Benefits, et cetera, philanthropy, private folks, and the National Governors Association to figure out, hey, what are the technology solutions to reduce our errors further? Larry?
So I hope we've successfully communicated that H.R. 1 is a sea change as far as how the social safety network is administered in this country and who can receive benefits because of it. Moving forward, we'd like to talk a little bit more about what we're doing to implement this in a way that minimizes harm and preserves lawful access to benefits. That is our North Star. That is what I came to DHS to do, and I'm working with my colleagues daily. It's incredibly important that we do this in a human-centered way that puts our clients at the center of this process. We need to build some practical solutions that have to do with just benefit eligibility more broadly, as well as work in partnership with some of the folks that Webb talked about earlier, specifically on payment error rate, but really much broadly to meet the moment. So I'm going to talk about some of those strategies. First of all, Maryland is in a much better spot than it might have been otherwise if we had not rolled out the One application. So the Maryland Benefits One application is really has significantly changed how we allow our customers to access a consolidated portal to apply for multiple benefits, not just SNAP. Importantly, because of all the work requirements that we talked about earlier, we also need to expand and deepen our SNAP employment and training partner network. So this past year, we went from 30 to 48 organizations that we're supporting for referrals from the program and increased funding by 19%. We know this is not going to meet the entire need, but it's a really important start. We also need to do everything we can to easily identify people who are accepted from the requirements of H.R. 1. So we are working with our community partners and just met with our CBOs again this morning to talk a little bit about their role in shepherding clients through the process, especially if they have changes to their application that might be impacted by the federal changes. We want to make sure that they are advocates and we're smoothing the mechanics as much as possible. We're communicating in a central way, so there's a link in the slides to our web portal that is both for anyone in this room who wants to get additional information, and it has resources that are client-facing as well as for advocates. In addition, we are looking outside the state for best practices. You know, we're going through this with our colleagues in every state across the country. Maryland was very lucky to actually get 2 grants through the Public Benefit Innovation Fund. One of those came to DHS and MDH and our partners on the Medicaid side to leverage AI and other tools to improve the customer experience. An example of this is having a customer-facing portal or bot that would make it easier to submit income verification documents. As we all prepare for taxes, we know that that can be very complicated to understand what you might need to submit. It's going to look different for people with W-2s than people who don't have W-2s, and we want to make sure that we're providing a seamless interface for clients. We're also working with the Maryland Healthcare Commission to use diagnostic data that would automatically kind of indicate if a client is unfit for work per the federal law. So that would be the CRISP database. In addition, we are partnering with a lot of our interagency partners and our community organizations and philanthropic partners to expand access and education. That is both for clients specifically, but also Deputy Secretary Perry Briskin and I are on a bit of a roadshow. If you want us to come to speak to any groups about how the law impacts SNAP and Medicaid recipients, we are more than happy to come and talk to folks and take any and all ideas for how we can do this work better. This is an additional resource slide. It has our portal. It has our employment and training page. It has food resources for folks who are not going to be able to preserve their access to SNAP. And it has our top line messaging. We're encouraging Marylanders to continue to update their information, check their eligibility, and apply for help at marylandbenefits.gov. We also have a call center, and that is listed here as well.
So with that, Madam Chair, we're happy to take questions.
Thank you. We'll start with Senator Lamb.
Thank you, Madam Chair. Thank you to both of you from the department. Really interesting, also really concerning. I guess just a few questions here. So one, with the folks that are seeking asylum or refugees, seems like these are individuals that are going to be thrown off. Are they just out of luck, or is there anything else that the state is doing to help those individuals who need SNAP or used to have SNAP?
So, Senator Lamb, I think let me address your question directly. The first part is if a member of the household does not immediately qualify, there may be another member of the household that does qualify. And so again, we're encouraging Marylanders to apply through marylandbenefits.gov. It'll run through eligibility, and we're basically trying to figure out how do we support and how do we help our customers to the extent possible. In addition, in partnership with Attorney General Brown, Maryland is a participant in multi-state federal litigation about how H.R. 1 is being implemented with respect to immigration provisions. And then the third part is, as my colleague mentioned, we're making the system fixes so that we can understand at a more granular level who are the customers that are being affected. And then that's a continuing thing. The changes went live on Friday, so we will probably have more information in the next month or two.
So short of, if there's another individual in that person's household, that asylum seeker's household who qualifies for SNAP, I guess directly they are out of luck right now.
Correct, sir.
Yeah, okay. It looks like you've made some good progress on caseworkers with vacancy, but I guess, and that looks like it's come down significantly, which is good. My question is in regards to turnover, because, vacancies is obviously a snapshot in time. I think with churn of potential employees or caseworkers that are coming in, that could also reduce the accuracy, come up kind of the throughput rate of folks who are reviewing these applications. What is the turnover like with these caseworkers? Vacancy looks good, but turnover.
Absolutely. And Senator Lamb, if there are two handouts on your desk, and I think we transmitted it digitally to you as well, sir. On page 2 of our Q&A, there's a lot of bullet points and specific information about the turnover rates. And specifically, it talks about what are the steps that we're doing to keep and hire more caseworkers. And so it's really important to note that as we bring on staff, we're training them, and then we're trying to do everything we can in cooperation with the Department of Budget and Management so that we can retain our caseworkers to the longest extent possible. And we're happy to report that our numbers are creeping up as we standardize training and retention efforts across the state.
So you're making progress with turnover?
Yes, sir.
Okay.
And I'll give you an example, sir. When I first started, I went to a training in Baltimore County, in Senator Jackson's district, actually. And the office, they started a training for new people. They put folks in a group of new folks in a dark room. The training was about 100 slides long. And I think you can imagine what 100 slides in a dark, warm room does to people in terms of retention. We've changed that to virtual, in-person, as well as smaller groups. And that training has been wonderful. I went to a recent training in Howard County, and the total slides were about 30 slides long. We had lots of engagement materials, and it seemed to me that our new employees got the material a lot more.
Along those lines, you referenced that like you're bringing a lot of folks in. There are things that you're doing to try to address these and reduce the error rate, which with that PER is really significant and important for the state. What is your sense of why we have so many? Why were we at 13%, for example? Is it, you mentioned bringing in more people to address the vacancy rate. Was this human error? Were there just not enough, state employees reviewing this, and it was leading to just general overlaps there? Or like, what was the root cause of all of this?
I think it's all of the above, Senator, from what you said. Again, like the three principal factors that we identified were staff, vacancies and training, IT, as well as federal and state policy changes. And so I'll address, going backwards, the policy change. Anytime you change SNAP policy and who is eligible, for example, immigration, as you referenced, sir, that adds a layer of complexity when you're looking at someone's application. The more tweaks, nuances, changes you make, the harder it is for someone, both our computer systems and our caseworkers, to look at, say, Webster's application and say, okay, yep, they checked the right boxes. So as part of the COVID emergency, there are huge numbers of changes. Maryland chose back then to serve Marylanders more. And so they received and got a lot of waivers for various public health emergency related items. All of those changes, when propagated across the state, resulted in a decent amount of policy-based change errors. Also, as I mentioned back then in 22, the vacancy rate was 19%. And as you pointed out, sir, the retention rate was low. We've systematically addressed all of those over the past 2 or 3 years to lower that number as much as possible.
So with the things that you described, it seems like the vast majority of them are all like personnel. So like getting more people, getting more eyes on these applications, getting more individual state employees to review them should drive, like that's really the heart of all that. That's your intention, right?
We believe so, Senator. And I think it's important to know, if you look at other states, let me see if I can go back in the slides, states with a low error rates, like South Dakota, if you look at them on the website, they have like a 3% rate. It's a small state with relatively restrictive SNAP policy changes. When you look at Maryland in relation to our peer states like New Jersey or Pennsylvania or Virginia, we're a lot closer in pack because our state, of course, has more people. There's a lot more complexity to SNAP policy. And you would argue that, I think you could argue that our SNAP eligibility criteria tends to be more humane. We're trying to be human-centered. We want to help people. And of course, that's going to create errors.
Okay. All right. I mean, I'm all for humane policy. That's why I was asking about the asylum and refugees. But, just obviously keep driving at that. Because as you could see from these numbers, this low, even the lowest error rate of $13, this is obviously a sampling, but it's, times however many, applications are being processed, it's leading to potentially $240 million plus of us losing federal, or we're on the hook to kind of cover the federal hole that they're no longer going to provide, right? So these little small errors, obviously tough to find, tough to kind of weed out, tough to capture. But, those $13 errors that, multiplied by whatever equals $240 million that we're on the hook for, which is really challenging.
We agree, sir.
Yeah. Thank you.
Thank you, Senator. Senator Kramer?
Thank you, Madam Chair. So Webster, just following up a little bit on Senator Lamb's inquiry there, and at the risk of being political, but I think if you have to be political, that's what you got to do. Looking at the timing and the dates of when we had the significant payment error rates that are now coming back to haunt us, am I correct that that was during the Hogan administration, where we found virtually every state agency was chronically underfunded, and we had chronic shortages of personnel in state agencies. And what I am gleaning from the conversation just now is those significant vacancy rates in this area are now costing Maryland taxpayers $250 million because of the failure to provide the necessary personnel to ensure that we were not having payment errors, and now it's coming home to roost. Is that an accurate assessment?
Yes, sir. We believe that is the case.
Okay, thank you very much. And then just quickly, if I understand correctly, by virtue of actions taken by the current White House, we are now going to have veterans, homeless people, and former foster youth under the age of 24 who are no longer exempted under what the prior standards were for certain employment requirements, and therefore they will either lose their benefits, and again, we're talking veterans, homeless, and foster youth losing their benefits if they cannot fulfill these new requirements coming down from the Trump administration. Is that inaccurate?
That is accurate, sir.
Assessment.
And it's more red tape, and it's a lot harder.
Wow. Okay. Thank you very much for the presentation. Thank you, Madam Chair.
Thank you, Senator, for your presentation. Senator Guile.
Thank you. Thank you, Madam Chair. Thank you, Senator Kramer. Thank you so much for this presentation. I wanted to ask a question. I think we're all interested in a slightly similar topic, but kind of a different issue, is the use of AI. And I'm curious, on this one page that you have, I guess these slides aren't numbered, but the page that says leveraging technology to reduce administrative burden, improve training, you indicate that you're rolling out AI-powered interactive training specifically for HR1 changes. And I'm sorry if I'm asking you a question of something you've already gone over, but what exactly, how are you utilizing AI in this?
Sure. So I'm happy to speak to that. I'll maybe just say to start, I've been in human services pretty much my whole career, and have heard that AI was going to transform human services for a long time. The past 5 months since I've been in this job is the first time I'm actually starting to see what that means, and I do think Maryland is leading in that space. So when it comes to the training tools, as we noted for the payment error rate, change drives errors because the caseworkers have to learn to do something differently than they've been doing sometimes for years and years and years. An example that we of how we're leveraging AI in training those caseworkers is taking the training that Webster mentioned, where you still go in person or virtually, you have the training, you get the action transmittal for all the new policies, and then when you're working in your at your station and you're dealing with customers, we have a AI that is trained on the manual that you just received, and you can query it. You can say, I have a household with a single parent who has a 15-year-old child. Are they still eligible for SNAP under the new laws? And they would come back and say no, because it used to be any dependents under 18 were exempt, and now you need to have children who are 13 and under. So that is the way to kind of check your work in real time. We are still encouraging our staff to talk to their supervisors and to make sure that they fully understand how the process works. We can't rely on AI alone, but it is a quick check, which historically you might have gone back to a document and looked on page 37, and you can just ask AI that's been trained on that document.
Okay, so these are inquiries that are coming from maybe existing recipients that are contacting for questions, or maybe somebody who has something pending, right? I guess what I'm really trying to get at is AI being utilized to review applications as far as determining eligibility?
So all of that is going to be done by, any eligibility determination will be made by a human, full stop. There are predictive analytics that AI can help direct the staffer or the supervisor to look at as they're making their final determination. AI will work on the front end and the back end, but there's always going to be a human involved.
Okay. Are you looking at ways to incorporate AI in reviewing applications and determining eligibility?
Yes. Sorry if that wasn't clear. It will be part of every step in different ways.
Okay.
So on the payment error rate specifically, one thing that AI can do is look at a case and say, based on what they see in the case, there are 2 fields that don't seem to match. And so then the supervisor will be directed to look at specific factors that are possible to be more likely to lead to an error, so they can identify the problem before it becomes an error.
But the key distinction, Senator, is it's not AI saying, okay, Larry application denied or Webster application approved. There's always a human involved in that actual determination. We want a human being to say, okay, the AI's recommended this. Is the AI correct? And so we're using AI to supplement and to help and to point perhaps in the right direction. So if Larry in the Webster household is rendered ineligible due to immigration, are there any other benefits? Could we steer the household to contact the Maryland Food Bank or what have you?
Okay. And just one last question, Madam Chair. So how does that compare to, is other states incorporating AI at the same pace or rate that Maryland? I think we all kind of want to take sort of a cautious approach, especially when it comes to certain government benefits, right? And have an individual, but at the same time, I can understand why this may help with efficiencies or maybe some this payment error rate issues and things like that. Yeah.
So my understanding from my previous federal role and the conversations that I've had is that we are ahead of a lot of our peers, but not by much. We're all learning together, and we're in conversations with other states as well as organizations that are helping states think about this. And it's really being driven by the implementation of the new law, recognizing that we can't keep doing it like we've been doing it.
Okay, sounds good. Thank you, Madam Chair.
Thank you. Senator Land, another question?
Yeah, I'm sorry. Just 2 quick money-related questions. So I know the Madam Chair had set up a briefing for this committee and I think another committee over the summertime where it looked like the worst-case scenario sounded like about $400 million that the state could be on the hook in just to maintain status quo in the program. Could you give us an update on that number? And maybe it's difficult because that 400 might have included the 240 million that was in here, or what is the latest number to just kind of update this committee on what it would take to keep the SNAP program whole at status quo?
So, Senator, I think if you look at slides 12 and 13, that's our most recent estimate. We estimate that for state fiscal year 27, the administrative fund impact is about $43 million. That's in the governor's budget. And then looking ahead, there may be an impact of up to $240 million if we're not able to lower our payment error rate.
So approximately 285 worst case scenario. Hopefully this 240 will be less as we reduce the PER, right?
Yes.
Yeah. Okay. So that's the updated number from. And then last question here on slide, these are not numbered, but you had referenced that 62 million was made available by the administration during the shutdown. I know there was some controversy as to whether or not states would be allowed to spend their own money to kind of backfill this. There was directions from the feds that you couldn't do that. Did we do that? Did we not do that at the end of the day? How much of the 62 million did we actually spend, and was any of that reimbursable back to the state once the federal government reopened?
Yes, sir. Working backwards from your question, we spent about $2.4 million of state funds to make Marylanders whole. And then there was a provision in, I think it's a continuing resolution that ended the federal shutdown, but partially fixed things, whatever it was, the things that are coming up again on Friday, that included a provision that said states could be reimbursed for state funds. And so Maryland intends to do so. We've been steadily asking our federal partners, how do we do that? And we look forward to the time when we can send them an invoice for reimbursement.
So you didn't have to spend the 62 million, correct?
At the time, sir, it was unclear.
Yeah.
And so Maryland took decisive action to ensure that Marylanders were not hungry.
Right. But you only, in the end, only spent 2.4, I guess.
Yes, sir.
Okay. And hopefully that can get reimbursed.
We expect it to be reimbursed, sir.
once you get some guidance from the feds.
Oh, we'll send them an invoice, sir, and if necessary, we'll see them in court again.
Okay, sounds good. Thank you.
Thank you, Senator. I don't see any other questions for this panel. So you're going to stay and do the update on the work group, pediatric group?
Yes, Madam Chair.
Should we have the Department of Health also come to the table, or should we?
Yes, I believe my colleague, Ms. Chesson, and also my colleague, Mr. Liggett-Creel, will join in.
Okay. Okay.
All right.
Yes, sir. You can start.
Good afternoon again, Madam Chair, Mr. Vice Chair, members of the committee. My name is Webster Yee. I serve as the Chief of Staff for the Maryland Department of Human Services. To my left is my colleague Stephen Liggett-Creel, Senior Advisor to Secretary Lopez. To my right is Ms. Sonia Chesson, Senior Advisor to Secretary Sejamani of the Maryland Department of Health. We're here to talk briefly about children in unlicensed settings and pediatric hospital overstays. We'll be followed by a panel of colleagues from a pediatric hospital overstay work group that was enacted by House Bill 962 of 2025, and I believe they'll introduce themselves at the appropriate time. First, we want to be very clear. There are about 3,700 youth in DHS care. There's a greater number that are in hospitals across the state. We want to be very, very, very clear. As of today, there are no DHS youth in a hotel or other unlicensed setting. Of the 3,700 youth that are in DHS out-of-home care, as of January 8th, there are 7 youth that are in the hospital experiencing a hospital overstay. This is a over 60% reduction from January 8th, 2025, when 20 youth were experiencing a hospital overstay. To be clear, that's 7 too many. We want to get to 0 as quickly and as safely as we can, but we are taking steady efforts in conjunction with our partners from the Maryland Department of Health and our hospital and other community health providers to reduce that number. It is really important to us that any placement decisions match this placement hierarchy. And I want to frame it up a little bit with, we want to first say thank you to the General Assembly. In 2024, the General Assembly passed a law that changed the presumption of placements from let's try to remove a child from a family setting and perhaps put them in an out-of-home care setting to a presumption of let's look for whether we can connect a youth to kin, whether by blood or by choice. That legislation took effect in October 2024, and over the past year, that has resulted in approximately 260 more youth placed with kin than in an out-of-home placement. So by attacking the demand side, we've already sharply reduced the total number of kids that have complex needs that might need something else. Because it's really clear to us, if we're surrounding a youth with kin, we're increasing permanency and better outcomes. Secondly, as you can see in this placement hierarchy, we've got foster homes, treatment foster care homes, congregate care settings, et cetera. What we found in 2023 was the lack of communication, and that's going to be our central message. There is a 211 press 4, and we're asking everyone, basically, all of our hospital colleagues, all of our local office colleagues, everyone that's involved in this, to pick up the phone and press 211 press 4. And that's the central key learning that we found, because folks weren't talking to each other. If Webster presented at Hopkins Emergency Department and a lower level staffer started talking to, say, Baltimore City or Prince George's County, they might not get anywhere. Whereas now, if we know about it through 211 press 4, folks can start working on it the moment Webster walks into the door. Hey, Webster has got this history. He needs perhaps XYZ provider assistance, and we can start that planning as early as possible. In addition, last year, House Bill 962 of 2025 enacted into law what is the definition of a hospital overstay. It's 48 hours after a youth has been medically cleared for discharge. The second factor that was also incredibly important was we didn't have a relationship with our providers. And we've taken the time both at the Department of Health and with the Department of Human Services, to reset that relationship. We started talking to our providers. We asked our providers, hey, what is it that we need, that you need, so that we can support you? And we found out certain roadblocks. If Webster came into the emergency room on a Sunday night at 3 in the morning, there might not be providers willing to pick up the phone at 3:45 saying, hey, I can take someone, or here's who I can take. Instead, it would be punted to, say, the next business day, 9 o'clock, 10 o'clock. And we've reset that relationship with our providers such that if you have a contract with the state of Maryland to provide beds, we can now reach you. We know what you're able to provide, and that greater type of communication has reduced the amount of friction and delay between knowing about a kid, helping the kid, getting the kid somewhere more permanent. And then the third part will be no surprise to this team. We've improved and standardized our training across the state. Previously, in 2023, each local jurisdiction might do things completely differently from a different jurisdiction next door. And I just talked through the next slide. So I'm going to go to point number 3. In addition to everything that I just said, 211 Press 4, statewide tracking, weekly meetings, better communications. We also asked a third-party organization, Chapin Hall, to do a placement needs assessment using quantitative and qualitative methods. And in the slides before you, they gave us a list of recommendations. All of these recommendations are currently underway. We're moving forward with implementing them, or we are completing them, and we'll be happy to talk about them in more detail. Where are we going? We are continuing to refine our statewide tracking tool, and we will iterate on our 2025 policies and reporting, documentation, tracking of youth, and pediatric hospital overstays. The next part is we also are supporting our provider placements, and we ran through a big package of provider contracts last September with the Board of Public Works. We will have another tranche of provider contracts that will likely be brought before the Board of Public Works this spring. In addition to just picking up the phone and talking to folks, we are doing weekly case management and placement case coordination so that both of the agencies and our hospital partners know about a kid, keep eyes on the kid, and escalate appropriately. As part of our provider capacity increase efforts, as I mentioned earlier, we've put over 260 kids with kin caregivers. We've built more beds, and by increasing our contracts by 92. And we are taking systematic work with all of our providers to say, how can we work together and partner in a greater capacity? This color-coded chart is one of those key changes. Prior to the most recent round of provider capacity reforms, Maryland had one-off idiosyncratic agreements with each provider. And one of the biggest changes is we've aligned more closely to what I think this committee is used to with Medicaid by providing categories of service. So if I'm the Stephen Leggett Creel provider facility, I will agree to provide classes, say, 2, 3, 4 of services, and say the Webster treatment facility will provide classes 5 and 6, and they'll know this is how much it costs, what are the services expected of them, and how can we serve someone better. And all of that has reduced the friction to help support our kids to the maximum extent possible. Before I turn it over to Ms. Chesson, I'll also note that Mr. Leggett Creel is here. He served both as the Prince George's County Department of Social Services as well as the Howard County Department of Social Services Directors. And so he's got, and in addition, he was a private provider, so he's got that wide spectrum experience, and he's been our lead on the human services side on this matter. And so, Ms. Chesson.
Thank you so much. Good afternoon, Chair Vital and Vice Chair Hayes and committee members. As Webb mentioned, I'm Sonia Chesson, Senior Advisor to the Secretary, and I'm really pleased to be here to talk a little bit about what the Maryland Health Department is doing to address the pediatric overstay issue. And I would say one of the most important things, ways that we think about this is that we want to work across the continuum, and particularly as far upstream as possible, to make sure that children don't end up in the hospital in the first place. So I'll talk a little bit about some on some of the things that we're doing there and our partnership with DHS in this space. So children do end up in the hospital, and so one of the things that we established, and this was started in 2024, is the Brook Lane Step Down pilot program. And this is really the state's first residential bridge program. It has 7 beds for young people, children 8 to 17 with complex high-intensity service needs. And these beds are really intended to be a short-term bridge when a child is medically ready for discharge, but while a placement has been found, there's not a bed available. And so the children come here and they get the full gamut of services until the bed in an RTC or somewhere else is available to them. Secondly, as Webb's already talked about, we launched 211 Press 4 as the single access point. It is part of the work that we are doing in our bed registry and referral system, which I'll speak about in a minute. And it really is intended to provide a service to hospital EDs so that they can help get connected to what are potential alternative placements or supports for children who are in overstay status. We implemented Project ECHO with the Kennedy Krager Institute, and the importance of this program is that it is a guided practice model that reduces health disparities in underserved areas of the state through innovative telementoring and hub-and-spoke system. It is really intended to strengthen our workforce to help care for children who have very complex needs. And that is probably one of the defining things that we find about the children who are in overstay status. They have complex needs, and training the workforce earlier on, and this is particularly a program that serves younger children, to understand how to care for these kids, we hope is, again, another way of preventing them ever having to be hospitalized in the first place. We are actively working on implementing the bed registry and referral system, and this is going to enable providers to quickly identify and seamlessly refer patients to inpatient and outpatient behavioral health services. It includes a searchable provider inventory, an electronic referral system, and connections to crisis support. We're excited. In November 2025, BBW approved the selected vendor. We entered into a contract with that vendor in December, and we have already had our formal kickoff meeting. This is a really important priority for MDH, and I think will make a big difference for hospitals who are actually looking for a variety of placements for children if they are in overstay, or before that, hopefully. There will be the searchable inventory. It will also include updated bed availability for inpatient psychiatric and residential crisis and treatment beds. We are amending the 1915I waiver, and this was a big contribution to the work of keeping children in the least restrictive setting, keeping them in their homes and communities. And it is a Medicaid state plan home and community-based benefit waiver. It supports that intensive community-based behavioral health benefit for children aged 0 to 18 years old who actually have a serious mental illness or serious emotional disturbance diagnosis, and it works with their families and guardians to maintain their integration in the community. It is a really important alternative to a more restrictive setting. It includes intensive home services, expressive and experiential therapies, respite and family, and peer support. But unfortunately, we were seeing this program being severely underutilized, with a participation falling almost at below 25% capacity. So our Behavioral Health Administration contracted with Health Management Associates to better understand why the waiver was so underutilized. And we learned that probably the biggest barrier is that the eligibility required such acute illness that there were not a lot of children who were eligible. So we've gone back, CMS has approved changes to the state plans, and we will be able to provide this waiver for a much broader group of young people. And then finally, we have heard concerns on the part of various behavioral health providers around our residential treatment centers units. And so the HOPE Act directs MDH to undertake a behavioral health rate setting study, and this study will allow MDH to review current community-based behavioral health provider rates in comparison to national and commercial rates. And it will also allow MDH to assess whether adjustments need to be made or whether new services should be added in the continuum and array within Medicaid. And then I'm going to speak a little bit about Senate Bill 696 and its implementation, but this is something that we are doing in close partnership with our colleagues at DHS and DJS as well. So we're in this one together. The bill I suggested outlined the need for us each to create the position of a hospital overstay coordinator, and that those coordinators would work closely together. And we have created those positions. We actually had people in those positions, but I think through a retirement and then I think a move off to med school, we lost the coordinators, but we have staff right now acting in those positions, and we both have identified candidates for the permanent position. Those coordinators are meeting together weekly. They're going through a list of of children who are in overstay status and working through with the hospitals and with the community providers, looking for options for those more challenging cases. They have also created an aggregate data report and are going to be reporting to the secretaries quarterly about those children. The second part of the bill really wanted, and the second piece of the coordination that we're doing is our senior leaders, both from DJS and MDH, have created an interagency meeting that has a much more policy level strategic component, and we have colleagues from DJS, DDA, MSDE, and GOC who are all part of this interagency group. And in fact, on business related matters, we are sort of streamlining that work through the GOC State Coordinating Council so as to leverage an existing coordinating body and not be starting from scratch. And finally, the bill established a 5-bed unit at our Rockville RICA, the Gilder RICA, for children who were in overstay status. So I have a little bit of a story to tell on this one. The majority of the children in overstay status who would be referred to this new unit at JLG, RICA, and Rockville would really be safer in a secure unit. However, only one cottage, Cottage 2 at Rockville RICA, is a secure building, and it currently houses the Facility for Children, which we call the FFC. The Facility for Children is a program that provides attainment services or competency restoration services for children who've been referred to MDH from detention. In order to open the overstay unit, we have to move the court-ordered FFC children to a different secure setting. So through conversations with our partners and colleagues at DJS, we believe we've come up with a solution that will serve all of the children's needs. DJS received money to provide inpatient SUD services by reopening the Noyes Center, which is also on that same Rockville campus. They have done the necessary renovations to the building to open this unit, but together we now believe that that building might be better suited to house the FFC program, which we know needs more space. We have children on the wait list for the FFC beds, and the state is at risk of being held in contempt for not admitting off of that wait list. In return, we will use one of the newly opened units in Cottage 2 to provide the SUD treatment services under the supervision of MDH. And so this trade, all sort of in that same area, will provide more FFC beds, but will also result in probably at least one, if not two, new units opened in Cottage 2 to take the children who are in overstay status and are in needing of an RTC placement. So that's the end of my slides.
Happy to take questions, Madam Chair.
Thank you. I do have questions. I was the sponsor of the Senate Bill 696 last year, so I have a few questions, and I've made some visits this year to some where there were overstays. So from your presentation, the 5 beds are not yet available.
No, Madam Chair, not yet. But
So that $3 million can come back in this year's budget? Because we funded $3 million for those 5 beds.
We have, the staffing has been hired, Madam Chair, so we're in the process of using the money to staff up.
Okay. So you still have 7 youth in hospital overstays. I'd like to know the number of days of each of those 7 youth. Can you get that back to me? Or if you, maybe you know it.
I'm gonna,
I don't know it off the top of my head, Madam Chair, but again, of the 7 youth, I believe 5 of them have placement plans, so they're due to be admitted. But we'll be happy to follow up with you.
So when does DHS or DSS take responsibility for those children that are in overstay situations?
So when a child is in an overstay, if they are already in our care and custody, they're ours, and they are under our, we're responsible for them. If a youth is identified after being in the ER or a hospital overstay and they come to the attention of the department takes responsibility at the time. We go through a VPA process. And so when that VPA is signed off by the parents.
What's VPA, please?
Voluntary placement agreement. When that agreement is signed off by the parents with the department, that's the moment the department has responsibility for the placement, care, and custody of that care of that child.
Thank you. So in one particular case I visited, this child had been there for 60 days. There was no care and custody taken by DHS. This child was in a room for 60 days, no treatment, couldn't go outside, had food and clothes. That was it. And I was told DHS doesn't take custody until they have a placement for children. And so they're languishing in emergency room overstay situations with no additional services from DHS. Now, was I given bad information?
No, assuming that that child was not already in our care and custody, we would take responsibility at the time the VPA is finalized.
So it's very possible that children are staying for these long periods of time with no VPA, and so you don't have care and custody.
Yeah, until the VPA is signed, we are actively involved in helping identify placements. We work closely with the family to work through the VPA, identify what services can be provided. Is there alternatives to being in that hospital, whether that's family or other kin related? I'm going through that list of things. But at the end of the day, if the recommendation and the need of that child is to a high residential level of care, we ultimately move through that process. When that is identified, the VPA is signed, and then the department places that child.
Doesn't it seem that it'd be very difficult for a child and a family to have 60 days waiting for that with no service, no services whatsoever, no education, no outdoor, nothing, for 60 daes? That's why I want to know how long these 7 youth have been in hospitals. I had a case where there were one child was in 100 days. So, you know, we need to be able to find placement, I think, obviously more quickly than 60 days. It's not fair to the children who need behavioral health or medication or, you know, whatever it is that we need to be helping the children. We're not helping the children to leave them in a facility like that for 60 days.
Right, and we agree, and we find it important to find placement, and that's one of the things where we have been working for over the last 2 years to identify and bring on additional provider capacity, not just beds, numbers, but making sure that those beds are in a position to serve the children that we talked about. Right, these are youth with some of these youth are with very complex needs and multifaceted needs, and so making sure we have providers that can do that. And so we talked about the releasing of statement of need and expanding those providers, working closely with some of our existing providers to build that bed capacity, which has helped us move from that 20 last year to the 7 this year.
Well, and I understand and agree with what you said. The children need the services, but they can't be left for 60 days or 100 days. That's where, you know, you need to find services. Are there out-of-state facilities? Can we transfer children out of state until we find beds in Maryland?
We currently do access, when we're looking for placements, we leave no stone unturned. So we are looking both internally. Obviously, the preference is to use an in-state provider. But if we can't get an in-state provider to move to a yes, then we also simultaneously are exploring out-of-state providers.
Well, I'd like the number of days for each of those 7 children and what facilities they're in, please. Ms. Chesson, I have a question for you. I understand the governor's budget included funding for adolescent inpatient substance use disorder treatment beds. Can these 5 beds we're talking about be used for that purpose? Or are these five beds that we're developing for the children that we're talking about that are in overstay?
Madam Chair, I think I'd probably have to look at which line item in the budget, whether we're talking about the substance use beds that we are funding come through DJS funding. So
Okay.
I'd
So
have
they're
to
not
better
using these
understand.
5 beds that we're trying to get open
I
in Cottage 2?
would have to make sure to
Okay.
get back to the team and
If you'll
better
get back to
understand
me
the
on that,
budget on
appreciate
that.
it. Thank you.
Yes.
I see questions from Senator Lamb.
Yeah, thank you, Madam Chair. So, you know, you referenced CJAMS, which is the replacement, I guess, for Chessie. And, you know, my understanding from a lot of the local DSS folks is that CJAMS has been really difficult to work with, has been very clunky. That's why they've had to resort to cataloging things on spreadsheets, that there are requests that come down from DHS Central, from headquarters, with different requests for numbers and updates and whatnot. And the system really just was not configured and has not been configured to be able to provide those real updates back to DHS in a fashion that's reportable and easy. And that's why they've resorted to this. You know, you referenced the fact that there have been changes made to CJAMS to make this better. You know, I guess, should we have any confidence that the local DSSs feel that this system is now better? Because I haven't heard any improvements. In fact, what I've heard up to this point was many of them actually preferred Chessie over CJAMS.
Yeah, so I mean, it's no secret, and we haven't been shy about sharing the struggles with CJAMS, and particularly how we found it at the time we all entered this into our roles. We've been identifying those areas where it's clunky and working to refine them and trying to move away from these individualized 24 different ways of tracking things. So speaking around particularly the overstay, you know, we were able to build that tracking system into CJAMS, so we weren't relying on a Excel spreadsheet or a third-party documentation. So we were able to move that so we have a better understanding of who is in overstay and you know, adjusting the policy. To the larger context of whether locals like it better than Chessie, I can't really speak to that. I know that CJAMS is better today than it was in 2023 when we got here. And we continue to take that feedback from our local departments on areas where we can improve. And you know, the development of CJAMS has its own set of limitations, whether they're fiscal or, you know, just person's power. But we continue to identify those critical things and make those changes to CJAMS as needed, both within our administration and social service administration, but also the other areas.
Okay. I mean, I'm glad that, you know, you continue to make some improvements. I think there are probably a lot of improvements that need to be made when it comes to CJAMS. I think from my perspective, the jury's still out as to whether or not this is adequate to a level that makes it easier for our local DSSs to be able to function, or if this is, you know, another added burden, which seems like, at least from what I've been hearing up to this point, is where we had been left at. But.
And Senator Lamb, I think as my colleague Stephen pointed out, the key thing we can do is we can listen. We can listen, we can say, here's how we can fix things, how do we partner together, get it on the list of things to do, and then to make that work. And so we heard both from the auditors and our local colleagues, hey, how do we get some type of health passport for our kids? That work started 18 months ago. We executed on procurement, and now we're in the implementation stage, so that by this summer, we're very hopeful that we'll have an electronic health passport that links in with CRISP, et cetera, to make that type of medication adherence and medical visit tracking possible. In addition to that, you know, if, as we hear from our local offices, hey, we need this feature or this thing doesn't work, we talk about it. Prior to this administration, folks were like, here's your burger, Merry Christmas.
I mean, I think to the point that you just brought up, I think listening is important. I think for what I've heard, though, from other local DSS agencies is that there is some reticence about being able to bring up concerns with DHS and headquarters because they're afraid of, retribution, of getting their head chewed off about issues that they bring up, that there's a lot of concern about an open level of communication that's available to the department. This is things that I've brought up in prior audit hearings over the interim as well. Not expecting you to have the solution to that, but, I think that's a very real concern if local DSSs are seeing a hemorrhage of individuals walking out their door because they're frustrated by the situation, that they're not able to bring up concerns openly in a receptive fashion with the department. And it's led to a lot of challenges. And so I'm not expecting an answer. I guess,
Senator Lamb, I must respectfully disagree with your statement. And the reason why is we have an open door policy. The directors of Anne Arundel County and the Howard County Departments of Social Services not only call me, they email me, they email my colleagues, and anytime there's an issue, we talk through it and we work together. We spent an enormous amount of time ensuring that our partnership with our local offices is as strong as possible. And in fact, with Mr. Leggett-Creel, with other key leadership, they are local directors that have been lifted up into management. And so the entire point is that every step of the way, we involve our local offices and ask for their input on how do we make things work, how do we make things work better.
This is not to any specific local DSS, so I know you identified two, but I'm just saying generally this is what I've heard from a few DSSs. On the Chapin Hill report, is that something that we have access to be able to see? Because you referenced this, I'm assuming this is an outside consultant that was brought in.
Sure, we'll send you a copy if you wish.
Okay. On the situation with Kanaya Ward at the hotel in Baltimore City, it sounds as though there was a contractor, Fenwick, which was brought in to be able to provide kind of that in-person kind of monitoring for that individual. Obviously, a very tragic case. This was an individual that was a ward of the state. This was our responsibility to make sure that we kept this young adult safe, and unfortunately fell short. It sounds like there was some report that was done by DHS as an after action that found that the monitor that was with Ms. Ward had been there for 53 hours or something. And that was somebody who's contracted with Fenwick. Since we are no longer housing individuals in hotels, which is a positive development that we've been pushing for years, I presume that these instances will not occur, and is Fenwick still contracted with the state? Because it looks like in this instance there was inadequate oversight of an outside contractor that was brought in to provide that monitoring, and then that led to the tragedy that we saw over the summer.
So first, everyone at the Department of Human Services are completely heartbroken by the loss of Kanaya Ward and her death. The well-being of our young people is our top priority. We will not rest until every child in the state is safe, thriving in a permanent home, and surrounded by a loving family. We have not had placements with Fenwick since September of 2025. And with respect to the procurement bids, we are in the final stages of a procurement of a set of contracts that we'll bring before the Board of Public Works, likely before the spring, for the next round of one-to-one providers contracts. They will have increased quality and reporting standards, and we hope to take from the lessons learned from the death of Ms. Ward to do better.
What kind of improved quality and standards are you anticipating as part of those new contracts?
Sure. And I don't think I can speak to the specific standards in exact detail, but Senator, I think the key point here is one-to-one providers prior to the statewide contracts were a matter of each local office with a provider. And so it was inconsistent. Anne Arundel County might have a set of providers that they used. Instead, we're now working we did 2 rounds of RFP, requests for proposals. The first was with Baltimore City and Anne Arundel County. That went through and was approved by the Board of Public Works, I believe in September of last year. That accounted for about 40% of the statewide youth. The other regions, Eastern, Southern, Western, and some of the central counties now are coming before. And again, the main point here is we're saying, hey, here's some basic consistent requirements. We're asking for quality standards, medication, et cetera. And Stephen, I'm sorry if I spoke over you. If you know any more about the specific details, we'll be happy to provide the RFP standards to you offline.
Okay. I mean, I would urge the department to please stay on top of this. It should
Yes.
not require the death of an individual under the state's care to have to lead to some of these systemic changes that need to take place. There's usually in these instances, as you know, there's not one single mistake that leads to this type of a failure. There's systemic level mistakes, and whether that's not being able to have the proper quality over these contractors, whether it's not built into the contractor's original terms that are provided by the state, there were multiple levels of failures here, and I'm hoping that with this tragedy, you'll be able to make sure that you stay on top of these contractors so that these one-on-ones do not fall short of expectations again.
We agree, Senator. And I also need to take reading lessons because I should look at the words in front of me. Specifically, the changes deal with minimum age, background clearances, required training, crisis intervention skills, and supervision standards. So that's the main changes, sir. And again,
And that's all positive. Just we need the department to stay up on top of those with the outside vendors.
we agree, sir.
Thank you.
Thank you, Senator. Senator Washington?
Thank you, Madam Chair, and thank you all for being here. I'm really interested in this Rika Gildner and the bill that the chair sponsored last year and that allocated. How much money was that for these 5 beds?
$3 million, sir.
$3 million for 5 beds.
Yes, it's three rounds of staff.
Got it. Okay, so it's capital money and also operations.
It is primarily to staff the unit.
Got it. But with adding 5 beds.
The
Got
5 beds, right?
Fair
The
enough,
5,
okay.
yeah.
Not building a new building or anything
No.
like that, just staffing it. Got it, makes sense. You know, I appreciate this because in Prince George's County, we don't have any behavioral health adolescent psychiatric beds at all. This is in Montgomery County, right?
Yes, sir.
And we have a shortage of services, behavioral health services in Prince George's County, and we have a shortage of psychiatric help within the county too. And I wonder what's the department's role in establishing a unit. I know the governor in his budget is offering additional dollars, but I don't know if there's concretely those going to go to a certain area. Or what's the criteria for that funding? But the need is significant in Prince George's, and I know that for certain. I know you all know that too. And so if you can speak to that for me and the plans that MDH has for, providing adequate care for those families.
Thank you for that question, Senator. So just to clarify, the RICAs are actually residential treatment. They are education centers. They're not psychiatric hospitals.
I know.
And so we have 2 state RICAs, one, as you pointed out, in Rockville and one at Baltimore. In the Baltimore, the one in Rockville is actually an MCPS, Montgomery County School, but the one in Baltimore serves a much broader set of schools. So those are the 2 in the state. There are many other RTCs that are privately run nonprofits, but those are the 2 state-run institutions that are educational institutions. As far as adolescent psychiatric beds, those are spread out across the hospitals across the state.
Across the hospitals in the state.
Yes, there are many hospitals that have adolescent psychiatric beds in addition to the psychiatric hospital.
Got it. I have a piece of legislation this year to discuss this topic, so we'd love to talk to you all afterwards.
Great, that would be wonderful. Thank you, Senator.
Thank you, Madam Chair. Just a quick question to follow up on questions that were just posed. I'm familiar with a situation where a hospital was adding juvenile pediatric beds, psychiatric beds. I think it were seven beds, I believe, and it took the hospital almost a decade to get it approved, and millions of dollars just to get it approved. And I know this is a little outside of the scope of what we're talking about, but I think it fits right into the plan of the issue of what's being addressed. And I was interested to know if the department had spent any time taking a step back and taking a worldly view of the situation to see if there's things within that approval process and how institutions or how private entities are able to get approved to offer these services, outside of the state, to facilitate that type of resource in Maryland, as opposed to just relying on the state. Has the department done anything to go back and look at its own approval procedures to expedite, how these different facilities are able to open?
Senator, let me make sure I'm understanding the question. You're talking about opening adolescent psychiatric beds in state hospitals, or I think you mentioned outside of the state.
Well, this is outside the state. This is in private hospitals.
So, outside, not literally outside of Maryland, but outside of the state system. Okay, I'm sorry, I misunderstood you. So,
and not just psychiatric, but other types of facilities. I mean, that's one detriment. I mean, if you do talk about different groups that are involved in this type of work, I mean, the first thing that comes up is well, we can't expand, we wouldn't expand because it takes forever to get approval from the state to open up a facility. Have you spent time to look at those concerns or criticisms?
Senator, I personally have not been part of that oversight, but I'm happy to take that question for the record and go back to the folks who do the licensing and understand better and get back to you.
Well, because I mean, it's not that's not rocket science. I mean, it's a pretty straightforward issue that I think ought to be just as important as the critical failures you're trying to address, in this discussion. But I mean, it's pretty common knowledge. And if I can help you with information, I'll be more than happy to give you some details and some examples.
That would be great, and we will look into that. Thank you, Senator.
Thank you.
I don't see any further questions for this panel. Thank you very much. That ends the hearing on the update on the work group on children in unlicensed settings. And now we'll move on to the actual work group in unlicensed settings and pediatric hospital overstays. Thank you, gentlemen, and Laura, thank you.
Thank you, Madam Chair.
So this is going to be Laura Edwards, Chair of the State Director of the Maryland Court Appointed Special Advocates. She chaired it. Erica Lamone, Advocacy Director for Children's Rights of Maryland. Robert Bassler, Associate Vice President of Our Child and Family Ministries. Jane Cranky, Assistant Vice President of Government Affairs at MHA, Maryland Hospital Association. Crystal Williams, Assistant Public Defender, Office of the Public Defender. And Edward Ted Gallo, Executive Director, Maryland State Council on Child Abuse and Neglect. Do we have enough chairs? We can pull one in on the end if we need to.
We got it.
Okay, good. So Laura, are you going to start for us?
Yes, Madam Chair, thank you. Madam Chair, Vice Chair, members, thank you very much for hosting us today and allowing us to have this opportunity to provide an update on the work group status. Just to level set, the work group initially was to convene in June. We were unable to convene in October when the actual initial report was due back out. We had a number of members that were not yet appointed and had to wait on those so that we could fully convene. We did start our meetings in October. We continued through, and we promised to provide an interim brief update with our final report due in April so that we could have further discussions. That being said, I wanted to say that we also introduced sub-work groups so that we could expedite some of our fact-finding and information gathering. With the sub-work groups included resource and barriers, definition history in other states, data and assessment of needs, legislation and policy. Each subgroup was tasked with providing a report back to the executive team and the rest of the work group members. And we had, the meetings were all open to the public. Therefore, we allowed other non-members to participate in those discussions. I'm going to pass this now over to my colleague, Jane.
I'm going to go
Oh,
over the priorities.
go ahead.
So briefly, regarding the priorities, we are,
Excuse me, you're Erica?
I'm sorry, Erica Lamont, Maryland Legal Aid. I'm the Advocacy Director for Children's Rights. Thank you. So our priorities, first, expand behavioral health and child welfare capacity. And you'll hear more about the priorities from my colleagues, but I just briefly will summarize a bit. Maryland lacks sufficient licensed placements in community-based behavioral health services. You've heard that a little earlier. If we are able to achieve the goal of expanding the behavioral health and child welfare capacity, it will reduce costly hospital boarding while preventing, developmental harm, trauma escalation, and as you heard, life-threatening outcomes for children. We also plan to ensure the state agency accountability and collaboration. Disjoined responsibility across state agencies has resulted in some delays. You'll hear more about that. If we can achieve that, we hope that this will provide strong accountability, which will shorten this length of stays and reduce duplicative spending and ensure children are placed in safe, regulated environments more quickly. Improved data is necessary, as some of you had mentioned before, Senator Lamb, and even our colleagues at DHS. We need real-time data to enable earlier intervention, lowering emergency care costs, and prevent prolonged exposure to unsafe, non-therapeutic settings. And then finally, to implement previously passed legislation. So we had multiple laws that have been passed but have not been enforced. And so implementing the enacted laws will maximize prior state investments and immediately improve child safety without requiring new statutory authority. And I'll pass to Crystal or Jane. Oh, Rob.
Good afternoon. My name is Rob Bassler. I am Associate Vice President at Arrow Child and Family Ministries. Arrow is a nonprofit who has contracts to provide residential services to young women to DHS. We provide therapeutic foster care. We also provide in-home intensive services through contracts both with DJS and as a 1959 waiver provider. In the category of expanding behavioral health care and child welfare capacity, I think one thing I want to preface by saying is one of the things we think is important is to really think about this holistically. That while many of the youth who end up in either hotels, previously were in hospital overstays now, are teens or young adults who have significant behavioral health and often developmental challenges, and there's a need for high-intensity beds to meet their needs. There also is a need for growth and services throughout the continuum of care, both prevent them from needing to be hospitalized in the first place, and also when a child goes to an RTC, when it's time for them to discharge, if we can't find another placement that is appropriate for that child will stay in an RTC and not free that bed up for the next young person who may be sitting in a hospital waiting for it. So some of our priorities are, one is to fully fund the Quality of Service Reform Initiative. That is an ongoing process in partnership with DHS, MDH, DJS, providers, to develop a new rate system for providers. In FY25, it was funded for residential providers. I can say as a residential provider, that increased funding allowed us to increase salaries to staff, to hire more staff. Before it was funded for a program that had a contract for 23 beds, we were averaging 16 beds at any given time. Once the funding allowed us to hire enough staff to operate at full capacity where we are now. It was in the budget for this current fiscal year to expand that funding increase to child placement agencies, so for private treatment, foster care, and independent living programs. The funding will end up being flat funded for all of those rates, so that was not able to go into effect. That would have increased compensation for foster parents, to change how we assess the needs of kids and funding for kids in care, and again, allow those providers to have competitive salaries for their staff. As an example, treatment foster care social workers or licensed social worker in treatment foster care program is probably making between $10,000 and $15,000 a year less than a social worker in another setting. In addition to that, we recommend implementing either START, which is an evidence-based crisis intervention program for young people with mental health and intellectual disabilities, or a similar model so that we have 24/7 community-based crisis intervention capacity for kids with the highest level of needs. Along with that, to fund, expand mobile crisis response, to create a state registry of foster homes and group homes so it is easy for DSS workers to identify families or settings who are appropriate for the youth that they are looking to find a placement for. Increasing Medicaid reimbursement for RTC providers, which you heard about before, as well as for respite and 1915I providers. I will say, as a 1959 intensive in-home provider, we have a rate for our contract with DJS. We have a rate for 1915I services. The 1959 rate is about 60% of our DJS rate. It does not cover the cost of providing that service. In addition, mandate OPEG audits for local management board funding priorities, ensure annual funding and PINs for RICAs so they can be fully staffed, and then to redirect state dollars to meet these recommendations. And finally, require the state to apply for federal grants to supplement state funds. One of the things that is available currently is there's a SAMHSA Children's Mental Health Initiative geared towards supporting improvement of state level systems of care, which is what we're talking about here. Now I'm going to pass it on to Jane.
Hi, good afternoon, Chair Beidel and members of the Senate Finance Committee. My name is Jane Krinke. I'm here on behalf of the Maryland Hospital Association. So for priority 2, there was agreement in the work group that we really need state agency accountability and collaboration to really address this ongoing issue. And first, so we were recommending that the legislature create a new position or create a permanent cross-agency oversight body within the Governor's Office of Children. There was a lot of discussion that the Governor's Office of Children seems like the right agency because they have their hands in all of the different agencies. So having a central location where that oversight body can live. And then creating a permanent children and youth state placement manager, someone that can be singularly responsible for these kids. Because there's an ongoing issue that there is not someone taking responsibility for these children and youth, especially if their parents or guardians aren't in the picture, the youth aren't in DHS care and custody. No one's really stepping up for them. And so that translates to the data as well. And Crystal will talk about the data recommendations, but I just wanted to take a minute to talk about the number of kids that are actually in an overstay status. So from Mr. Yee with DHS said that there are 7, but that's only the kids in the care and custody of DHS. There's actually closer to 32. So I will commend the state, MDH, DHS, DGS, they worked together to create a count as of January 8th. And they found that there are 32 youth experiencing a hospital overstay, excluding some of the infants that are in different facilities, but 32. 25 of these youth were in inpatient units and in hospitals. 7 were in emergency departments. It breaks down to 12 girls, 20 boys, ranging in age from 7 to 20, with an average age of 14. So a lot of them are the teens that Rob was talking about. If you look at the youth that are known to DHS, so you have the 7 that are formally in care and custody, then you have 9 that are pending a voluntary placement agreement, which I think Mr. Liggett-Krill to explain what that is. So they're known to DHS, they will be in their care and custody once they're in an RTC. And then 5 of the youth and their families were working with DHS. So of the 32, that's 21 that are known to DHS, that are in our hospitals living there. And we do count hospitals as unlicensed settings because they're not licensed for children to be living there, for foster youth. So our numbers tend to be different, but I know the state's working to have a more inclusive count. But just wanted to say that there's closer to 32 than 7. Other recommendations were to establish a placement review panel. I believe this recommendation came from the Cheap and Hall report that was referenced earlier, and making sure it's a multidisciplinary panel. And then also recommending that this placement manager convene a rapid response placement team. So if a youth is in an unlicensed setting more than 72 hours. And again, so these youth that are in an overstay status, they've been medically clear. They don't have any reason to be in an acute care setting. And so urgency is really important here. And we think having a rapid response will help them get to an appropriate setting. And then finally, creating an oversight body of stakeholders, like members from the work group, to hold the state accountable, review policies, and make recommendations. Having some kind of permanent structure. And then finally, identifying and removing loopholes that allow youth to be placed in unlicensed settings and prohibiting this practice, and then mandating that there's some kind of reporting whenever a child is in an unlicensed setting, just to ensure that, again, we're keeping track of these youth. And I'll pass it over to Crystal for the data recommendations.
Good afternoon, Senator Beidel, Vice Chair Hayes. Thank you for having us here today, and thank you for your work that you've done on this really important issue. I know that this is something that we all should be taking very seriously when it comes to protecting children, that we are essentially responsible for their care and protection when they're not getting that care and protection within their homes. And so one of the things that the Office of the Public Defender, why we are invested in making sure that we are part of this process. I'm here on behalf of our public defender, Natasha Dartigue, as a designee for our agency. But we do represent children who do come in through the psychiatric emergency room and do then eventually become hospital overstays when they are not properly placed. And so we have in the past filed habeas motions trying to get them out, trying to get judges' orders. And so it is still an ongoing problem that has continued. And I do want to address three kind of overarching issues when it deals with data before I get into the specific priorities that seem to be some reoccurring themes that need to be elevated when we are looking at data, when we're looking at how to collect data and to assess what needs to be done with that actual information. And so one of the most important things that I think is important to elevate is that we underestimate the actual harms of children in hospitals. There is an urgency to get these children out because they are actively being harmed by being in hospitals. I think it's a bit of a misnomer when a child is, said to be in a hospital. You think of it as a care setting, and they're getting treatment. That is completely false in terms of these are children who should have been discharged. They are medically cleared. They no longer have a need to be in the hospital setting, and when they are there beyond that required need, that causes them harm. And so I just also want to share a very quick example of the egregious harms that happens to children when they are in these settings when they should not be. Is one of the recent compliance reports for the consent decree in Baltimore City highlighted an instance where a child has gone through a number of traumatic instances and events and abuses before coming to the hospital setting. When he gets there, he experiences being assaulted by other psychiatric patients that are there, actually physically assaulted and harmed, and this is a child who previously had physical harms, brain damage from prior abuse and neglect. And so he's then exposed to additional chaos, additional situations that can actually harm him. He is subjected to being actually sedated and injected with psychotropic medication. These are things that have lasting effects on children when they are in a hospital. And so it just kind of creates a cycle. So that is, I want to say, one thing that we need to understand, that we need to get those children out of there now. This is something that needs to happen yesterday, days, months, years ago. These children need to get out now. As the department said, 7 is too many, 22, 32, those numbers should be 0. And so that is our aim, that is our goal. The other thing I want to highlight is that the over-reliance on placing kids in RTCs, and that seems to be a bit of a blockade in terms of getting these kids out, and that there's a reliance on just only looking at that siloed option. And so we do need to make sure that there are other options available in the community. The statute calls for less restrictive settings, and so it is concerning when the departments are speaking to more secure settings versus less restrictive settings to remove these children from the hospital setting. And one last overarching point I want to speak to when you're looking at the data is most of these children are Black boys who are experiencing incredible racial disparities that have been reoccurring. And one of the objectives should be and has been asked of the departments to invest in making sure that these racial disparities are addressed and that they are reduced. But I also think that there might be some additional information that needs to be looked into in terms of how these kids might be getting labeled when they have trauma, when they have certain behavioral issues that are not actually mental illnesses or developmental disabilities, but it's a result of their trauma and how they're being labeled, and maybe some implicit biases that might be playing into where they're getting placed, who's rejecting them, who's denying them, are they getting accepted, and also a lack of resources across the state that is actually addressing those particular populations and where they could get those services and resources. So regionally looking at where that money is going, where the resources are going, and how it's being used for specific populations of youth within the system. And so I will say that when we are looking at improving the data and the tracking and the sharing of the data, it is incredibly important to have a centralized system. Right now, it is very siloed in different agencies, different databases, different portals, different practices of entering the data. And so that's why we're getting a disparate number, a different number from one entity to the next. That should not happen. Children should not be getting lost in the numbers. We should know exactly where they are, how long they've been there, and when they need to leave. And there should be an option for them at that immediate red flag of their time to leave. And so that is one of the most important things, is just getting all that data in a centralized place where there's proper oversight. And so that would require some additional steps of making sure that there are state-mandated standardized data metrics to ensure that all agencies, all entities are actually capturing, collecting, and coordinating the same data metrics so that kids are not getting lost in the system. Additionally, we want to make sure that there are heightened reporting requirements, and I know that there are a lot of reports out there. There's a lot of mandates for reporting information, but it's important that when we create, or we're suggesting that there should be one centralized place, that there is that additional compliance of reporting to make sure that they are following through, making sure that they are providing more frequent updates on the progress and the specifics of what is actually happening to ensure that children are actually being removed timely and that they're not staying there beyond their designated time. And so making sure that these reports are also available to the public and that there is additional information, that it's not 2 years old or months old data that is getting published or provided, and that it's complete, comprehensive, and accessible to this body and to the public. And so that is our last priority in terms of the third priority in terms of our overarching issues and problems that we are seeing that need to be addressed. And so we do have a couple examples of legislation that we have proposed that could potentially provide more immediate fixes during this particular legislative session. And so our priority number 4 is to basically give more teeth to legislation that's already been passed, take another look at it, make sure that there are proper mechanisms in place to make sure that they're working the way that they were intended. And so I will just briefly walk through those bills, if you'll indulge me. So I have first the HB 1121, Chapter 29. This is a bill that was passed in 2020, and it is for the mental health registry and referral system. The purpose of this bill was to develop and implement a system in collaboration with state-designed health information exchange to make sure that emergency stays were reduced to get that backlog of individuals that are coming into the hospital system on an emergency basis, on a crisis basis, to make sure that they have access to services and that there is a system that's updating what's actually available and what the capacity is. The problem is that that has not been fully implemented. It has not been fully given the resources it needs to actually work effectively. There's still some discord between some of how the information is being reported. Again, some of that data issues in terms of who's inputting the information, who's getting access to it, but also how much information is being put in there. So it doesn't provide all of the available resources that are actually out there. And so making sure that it's more comprehensive in terms of what it actually is providing a daily report on. And so I know that there are additional things that could be done to kind of help get that off the ground and to tighten up the referral system. Additionally, for HB 766, Chapter 500, which previously passed in 2022, this is a bill that involves making sure that the responsibility of the behavioral health system this shifts the responsibility to the behavioral health system outside of the Department of Social Services to provide access for funding, education funding for when kids are actually in an RTC. And I believe some of the members touched on that earlier, and Senator Vidal, you mentioned when you went to the hospital, you saw that children are not getting education services. If they are outside of their local school system for, I believe it's about 10 days, they're withdrawn. And there's actually policies in place that prevent them from getting educational services while they are awaiting placement. And so they could be in a hospital setting, removed from their local school system, and now they're awaiting placement, and they're prevented from getting any access to actual education services or funding to make sure that those services are being provided when they're in that waiting period. And so there needs to be additional attention to how that funding can be accessible, but also, more importantly, that the kids are getting the education that they need, especially kids who are federally mandated to receive special education services, making sure that there's accountability, that those services are actually being provided, and that they're not just put on hold while the child is in the hospital setting in a waiting placement. An additional incredibly important aspect of one of our recommendations is the HB 322, Chapter 329, SB 255, Chapter 378, which was passed in 2023. And this is around the initiative to make sure that we are utilizing community resources, home-based resources, investing in services that will provide that wraparound support. We know that the services are there, the providers are there, some of the funding is there. There just needs to be more coordination and parallel investment to actually make sure that systems are working. So if you're pouring money into getting more case management, which this bill previously did, that you're also pouring money into actual step-down crisis interventions and additional placements to provide entire comprehensive wraparound services in the communities to prevent kids from actually going into the hospital in the first place when there are issues of behavioral problems or things that need to be addressed therapeutically and trauma-informed. And lastly, there is HB 1134, SB 403, which passed last year in 2024, I guess now 2 years ago. And this is a bill that addresses the accreditation for residential treatment centers and just to essentially tighten up the accreditation standards. It is my understanding that the department has recently introduced some regulations on that, so there is some progress in that aspect. But again, we want to highlight that that should not be the default. That is a very, very narrow, specific need, a very, very small population of kids who may actually qualify or be eligible for an RTC. And so we need to look in other areas in terms of how we do that. But this bill would also tighten the accreditation issues to make sure that the current problems with RTCs is addressed in a way that when children go there, they aren't experiencing further issues of harm in the actual RTCs. But thank you very much. I appreciate the time. And I'll pass it to...
Can I make two comments before, I think one more person's going to speak, right? First, your request for legislation came in very, very late. In fact, we didn't get it in time on Friday to request anything. But the House is trying to work on it. They had like a placeholder in. And so there'll be some things addressed. I know you got started late, and it's a very long list, but you know, I'm working with Chair Bagnall, and we'll get some of the things addressed. I'm a little offended because you listed 5 House bills and not the corresponding Senate bills. And then you come to the Senate.
We corrected that.
Madam Chair, I want you to know, I actually, that was one of the first things I noticed, and I did send an update, and it doesn't sound like it got to you, but I acknowledge that, and I thought you would be offended, and I did not want that to happen.
Well, I think this committee has really worked with this issue to try to help the children, and so I just want to make sure you understand that we need to be acknowledged for the work we've done too.
100%,
I
yes.
think the last person to speak is Ted Gallo. Ted, right? No? No one
I
else
just
is?
wanted to close everything out.
Oh, that's everything.
Yes,
Okay.
ma'am.
All right, so I see that Senator Washington has a question.
Yes, thank you, Madam Chair, and great presentation, and I look forward to, I wanted to go to those 5 bills that the chair was speaking to, because since 2020, we've been passing bill after bill. It looks like every year we're passing a bill on this topic. Of those bills, and I haven't read them all, but who's the main leader or main person, main entity responsible for implementing those, and what's the holdup on? Because your recommendation is to fully implement all of these, right? Because they're law. Do you have a diagram that shows who's the responsible party for each part of the legislation since 2020 that has not been fully implemented? And in your opinion, in your work group, can you say definitively that all of those 5 bills have not been implemented with fidelity?
So yes, and we do actually have a summary chart that we had started. I believe it was included in underneath some of our more expansive legislative recommendations that we did send. I'll make sure that you and all the members of the committee get a copy. But it does outline the responsible agencies under each bill, what it should have done, what has not yet been done. And so that has been part of our task, is going through the legislation and figuring out where areas that need to be strengthened, revisited, rather than just constantly recycling or reintroducing legislation when there's already laws on the books that can be worked with.
So does your report identify all those agencies that are responsible?
Yes.
And I wish you would have had a slide of that that showed us who are responsible, because we passed legislation with the intent that these are going to get done, and for those folks that aren't getting done, we need to hold them accountable, have them in front of us and ask, why hasn't this been done? And so I think it's almost a missed opportunity, but I think hopefully with the bill package that you're going to send to us, we're able to resolve some of these, the ambiguity, I guess, and making sure these get done. Thank you.
Yes, thank you.
Thank you, Senator. Senator Gallo?
Thank you, Madam Chair, and thank you for this presentation and the work that you all have done on this work group. I'm not sure who may be the most appropriate person to answer this question, but I think Jane kind of touched upon this earlier. Can you help me understand the different workflows between finding placements for children in DHS custody versus children whose families are unable to support them at home but do not relinquish guardianship?
Good question, and it might be a
You could like kick it over to someone else.
Sure. So, Ms. You're right, there is a difference, and usually when families come in because they're not able to care for their child successfully at home, that's when the discussion about a voluntary placement agreement comes up, and that's still within DHS purview. But the legislation that passed, I forget which bill it was, around the education funding, the purpose was to shift it from DHS to MDH. So I don't know, Rob, if you want to talk more about like the voluntary placement agreement process. But it's right now with DHS, but it's supposed to be moving to MDH.
Yeah, as a provider, I'll just say first, as a provider, we get referrals from local DSSs almost every day. My treatment foster care program last year received about 1,200 individual referrals. About half of those were repeats. And from our perspective, what we see a lot is when we talk with folks in local DSSs who are responsible for making those referrals, and some DSSs have like a placement office that's dedicated, smaller ones individual caseworkers may be doing the work. What we're told is there's not a good system to kind of update them on who has what beds available at any given time. So very often they will just send a referral to everybody. So my group home for teenage girls, and this has gotten much better, so I do want to acknowledge that, but okay, we'll still get a referral for a 12-year-old boy because we're on the email list and it goes out. And that's a waste of time. For my team, it's a waste of time for the DSS worker. Having a system where they know, Arrow has 2 beds available in their group home would be very helpful. As for the VPAs, on the referral side, once a VPA, they're kind of included in that whole referral process. So I'm not as familiar with sort of the process of getting families to that point.
Okay. And just one quick question, I guess, for the lawyers on the panel, for either Ms. Lamont or Ms. Williams. Can you tell me what are the factors that have to be in place for a child to be entitled to services of either CASA or Public Defender's Office?
So,
how do they get your services? How can they be entitled to your service?
So we represent children who, where the department has filed a petition in the court. So as soon as the petition is filed or shelter request has been filed, the court appoints an attorney for that child. So that's a little different than, so these would be the kids in state care.
Okay.
All of them are entitled to an attorney. All of them are assigned an attorney. As far as the CASA concern, Laura, I can.
It's a similar process, but not a guaranteed that every youth that enters the foster care system will be appointed a CASA. It is jurisdiction by jurisdiction based, and the judge makes that decisioning.
Okay.
We also represent children.
May the microphone be.
Oh, I'm sorry. We also represent children who have voluntary placement agreements in place.
Okay. And when you do represent a child, what is your ability to advocate on the child's behalf with DHS or DSS, like to compel them to provide required services?
So we absolutely advocate for the required services. We use the courts. We try to work with the department. We use all kind of different methods. Sometimes we, have to file emergency hearings to enforce certain things. So those are all different things that we use to try to enact. We work with the schools to try to get the children the educational services that they need. In working with the department, sometimes it is a little inconsistent in whether we're included in the meetings that you heard DHS talk about, the weekly meetings. It does vary whether the attorney is included. We would like to be included in all of those meetings so that we can help. We do lots of different things to try to secure placements. Sometimes we actually call the providers ourselves. Sometimes we attend the interviews. We try to prep our clients for the interviews. But I do want to say something that I was thinking of during our presentation, something that Crystal kind of brought up. RTCs are not permanent placements. So we have to remember that. And they're absolutely not appropriate for everything. But yes, we do a lot of advocating for our clients in different avenues.
But if DSS won't take custody, then the children are not represented. Is that true?
That's
You're nodding
true.
your head. Okay. All right. Thank you. Thank you, Madam Chair.
Thank you, Senator. And Senator Lamb?
Thank you, Madam Chair. This question, I guess, Ms. Cranky, you had brought up unlicensed settings, and I think in the fall, the department had issued a policy stating that office buildings, for example, are not considered, or the office buildings are considered unlicensed settings, right? And so that prohibited children from staying in those types of locations. So we shouldn't be housing kids in office buildings. You, I think, brought up the fact that hospitals were not included in the policy as an unlicensed facility. Do you have any understanding why that was the case?
That's a great question. I'm not sure why they weren't included. I think that's a good question. I'm not sure why. From the hospital perspective, yeah, we think of them as unlicensed to care for foster youth. I think I'm trying to remember back to what those policy directives from DHS said, if they're planning to issue a policy later, but I'm not sure.
Yeah, I mean, I guess, I recall that we had a hearing over the interim in the Joint Audit Committee. This was back in October, I think, where DHS had committed to adjusting a policy to include hospitals in the guidance that they are not, that they are unlicensed settings, right? So that children should not be housed in hospitals. and to do that within a year. It sounds like you have not received an update on that adjustment or that guidance.
Not to my knowledge.
Okay. Has any additional requests gone to DHS for clarification for that pending update?
MHA hasn't submitted a request.
Okay.
Great suggestion.
I know we have departmental representatives who are still here, but if they can follow up with us afterwards on the status of that, that would be helpful. Because I think from the hospital's perspective, you would prefer to have that guidance saying that you're an unlicensed setting for these youth, so they're not housed in hospitals, so to speak.
Yeah, that's correct. These children have no medical need for an acute care setting, like in an emergency department, inpatient acute psych. So they're only there because there's nowhere else to go, which isn't appropriate for them to be living there for weeks and months on end.
Right. So just to be clear, these are individuals that are medically cleared.
Yep.
There's no medical reason for them to remain in the hospital, but they're basically being boarded there, almost like a hotel, but not really.
Yep.
But taking up a bed that could be allocated to someone who does have actual medical needs.
Correct, especially for like the pediatric ERs. That's a huge concern. I know Johns Hopkins has talked about their concern around that, and they have some data. We can maybe follow up with you. Just the impact, especially even the small emergency departments around the state. If you take up one bed, you can think about the number of patients that could utilize that each day for medical needs. So it's a huge impact. In addition to the children, I mean, emergency departments are not therapeutic. They're loud, they're noisy. There's all kinds of things. People have their worst days of their lives there. It's not a place for these kids to be living.
Right. Okay. If the departmental folks could get back to us on that, that would be great. Thank you.
Thank you, Senator. So, Jane, you said there's 32 children right now being held over.
Yes, the most
So,
active. Yep.
I asked earlier for the list of 7. Can I have the list of your 32, where they're being held and how long they've been there?
Sure. It's the data from the state, so I can connect with them to share it with you.
Okay.
Yeah, it breaks. They have data by the hospital and county where the children are from.
There's a big difference between 7 and 32.
Correct.
Thank you very much. Do I have any other questions for this panel? Thank you all very much.
Thank you.
Committee, we're going to take a 5-minute break while we switch over to bill hearings. No, she came back.
Sorry.